It Okay. So, good evening, everybody. Thanks for joining. And I am doing the moderation part in place of Dr. Smith here, who is unfortunately not available. So, it's my great privilege to be inviting Dr. R. Suresh Kumar sir, who will be giving us a talk on coarctation diagnosis and management. Sir is senior consultant and the head of department of pediatric cardiology and ECHD in Believers International Heart Center, Believers Church Medical College Hospital in Tiruvalla, Kerala. Good evening and welcome, sir. I would also like to welcome our panelists, Dr. PV Suresh sir from Narayana, Bangalore, Manoj Kumar sir, our teacher from PGI, Durga Devi, my batchmate, she's in Chettinad Health City, Chennai. And lastly, our dear junior Lipi, Dr. Lipi Uppal, who is in GMCH 32 Chandigarh itself. So with that, sir, Dr. Suresh Kumar, sir, all over to you, and let's hear from you about coarctation of aorta. Thank you.
Thank you, Saujatya. The reason that we are choosing this topic to discuss in the continuity of fetal cardiology, pediatric cardiology, and adult congenital heart disease, coarctation illustrates the continuum of care that is required. Because you need to diagnose this in the fetus, at least those cases which are likely to give you trouble as a newborn. You need to know how to manage it in the newborn, both surgically and interventionally. The decision making is important. You need to know how to follow up a repaired coarctation or a native coarctation that is mild, and you need to deal with it when they present in even late adulthood. So this is a very peculiar problem that reflects the continuum of care that is required in the field of pediatric and adult congenital cardiology. We can start by defining coarctation, which all of us know is a narrowing of the aorta at any point from the transverse arch down to the iliac bifurcation. Having said that, 98% of coarctations are actually juxtaductal. There is a slight male predominance. And coarctation, we would like it to be discrete, but it doesn't happen quite often. If all coarctations were like this, there would be an interventionist dream, and it would be fairly easy to manage. But that's not the case. Quite often, the aortic arch in coarctation is hypoplastic. And depending on how young your child is, the coarctation is associated with more and more amount of hypoplasia. In 3 different series that I've been associated with, the first I was not associated with, but the surgeon is closely known to me, Professor Francois Lecourguet, my colleague in Muscat. In a series in 1995, with a mean age of 13 days, he had hypoplasia in 81%. When my group reported a series from Abu Dhabi, with a mean age of 41 days, hypoplasia was there in 38%. When we reported from Muscat with a mean age of 9 days, hypoplasia was there in 7 days. So the message, the younger the child, the more likely coarctation is going to be associated with hypoplasia of the arch. Now, this is how bad it can be. Look at this arch. The arch is hypoplastic. This one worse. And then the isthmus is tortuous. And there is a localized juxtaductal coarctation. But the localized juxtaductal coarctation alone doesn't describe what is happening to this. That is why that arch and isthmial hypoplasia with coarc is the way to describe. Since we are using the term arch hypoplasia quite often, it's very important for the youngsters to know how we measure aortic arch. We start by measuring the distal ascending aorta just before the brachiocephalic artery. Then we can measure the proximal arch after the brachiocephalic, before the left common carotid. Then the distal arch we measure like this, and the isthmus after the left subclavian artery. These measurements are important. We would also measure the aortic arch, the descending aorta at the level of the diaphragm. That is our standard. So when do you say that an arch is hypoplastic? There have been different definitions, all of which are describing the same thing in different ways. If you see that the arch diameter is less than 50% of the descending aorta at the level of the diaphragm, it is hypoplasia. The surgeons would like to remember Professor Roger Mee's teaching that whenever you see an arch, look at the weight. Weight plus 1 millimeter is what the arch should be like. If it is less than that, it is hypoplastic. In the day of Z-scores, anything less than -2 is hypoplasia. But I must warn you that the most available Z-scores, like parameters available online, gives our arches, as an Indian arches, as terribly hypoplastic, even when we feel that at times they can be left alone without specifically addressing. So using multiple parameters would enhance accuracy. And why is it that we are speaking of arch hypoplasia this much? Because it's a determinant of surgical strategy in the newborn. For instance, if there is no arch hypoplasia, a left thoracotomy is enough. While if there is a proximal arch hypoplasia, you need a median sternotomy, you need antegrade cerebral perfusion. Also, whether it's a simple resection and end-to-end anastomosis versus extended resection and end-to-end anastomosis, arch hypoplasia would decide. Whether any other technique like a subclavian flap augmentation is required, also an arch hypoplasia would decide. And the determinant of surgical outcome, arch hypoplasia is an important factor. The first image that I showed, the very neat, discrete coarctation would have excellent outcome, whatever you do. But if you have the type of arch that I showed in the CT angiograms, mortality and freedom from mortality would be higher and freedom from re-intervention would be low. When we are planning interventional strategy also as to whether it could be balloon, stent, or an arch stenting and how to do it, again, the presence or absence of arch hypoplasia is important. How do you diagnose coarctation in presence of a ductus? When you're seeing a newborn, say day 2, day 3 baby, or even younger, the baby has a large ductus, the baby has bounding pedal pulses, it could still be concealing an important evolving coarctation. Because in this setting, a posterior shelf may not be visible, and there is no gradient because the large ductus takes care of that. So we need to look at some of the other parameters to suspect or diagnose coarctation in this setting. One of the things that can be used here is looking at the distal transverse arch. If the distal transverse arch is badly hypoplastic, chances are that there is significant coarctation. Now, how do you say it is badly hypoplastic? The distal transverse arch should be wider than it is longer. In other words, measure the length of the distal transverse arch and measure the diameter of the distal transverse arch. If it is a length that is longer, more likely it is hypoplastic. In fact, if that the diameter by length ratio is less than 0.885, there is very likely associated coarctation. You could also relate the aortic isthmus diameter to the descending aorta at the level of the diaphragm and see whether it is less than 2/3. So these are the sort of things that will help us in diagnosing coarctation in presence of PDA. But the message is, see the baby serially. When in doubt, keep the baby in the NICU. Watch the baby for a few days. Usually time will answer the question. And look at this neonatal presentation. A 36-hour-old infant has increasing pallor, tachypnea, and respiratory distress. Physical examination shows features of heart failure, poor pulses in the upper extremities, and absent pulses in the lower extremities. This is a classical presentation of coarctation in a neonate which has crashed and is presenting in shock. This is a setting where prostaglandin can be life-saving. The opening the ductus, it can supply descending aortic perfusion if coarctation is extreme, or provide wider lumen at the coarc site and provide antegrade flow in a less severe coarctation. Let us look at some of these cases. In fact, these two cases are from my study in my Muscat Center. A 30-week-old preterm baby, 1.4 kg, presenting in shock on day 9. There was severe ischial coarct. The descending aorta was 5 millimeter and the arch was 3 millimeter. The baby was stabilized overnight on prostin and inotropes. It underwent a simple resection and end-to-end anastomosis, and there was excellent result. You can see this. This is the arch. It's not bad. It's predominantly a discrete coarctation. The distal arch is a little small, but this type of baby would respond well to a resection with end-to-end anastomosis. A little older baby, 1 month, weight 2.8 kg, presenting with a upper limb hypertension and a gradient between upper limb and lower limb of 60. Shows both proximal and distal arch hypoplasia with coarctation. This baby actually underwent resection and extended end-to-end anastomosis. There was a lot of discussion as to whether we should go from the front and with antegrade cerebral perfusion do a repair. It was eventually decided by the surgeon to do an extended resection and end-to-end anastomosis. The child ended with a 10 millimeter gradient. This is the typical coarctation. You can see that the arch is progressively narrowing. You can see the blood squeezing past the tight coarctation, and the tiny whiff of the ductus jet. In older infants, coarctation can present with heart failure beginning in the first month. A pediatrician might notice that the pulses are weak in the lower limbs. The pediatrician may pick up the murmur or a bruit in the back. Upper limb hypertension we have already mentioned. Or the baby may present with congestive heart failure. The echo may simulate a dilated cardiomyopathy unless you are diligently looking for arch. Say that type of a baby may present like this. After a few days of poor feeding and tachypnea, a 6 weeks old baby presents with hypotension, absent femoral pulses, and severe metabolic acidosis. A gallop is audible, and the heart appears enlarged on chest X-ray. Hepatomegaly is marked, and the LV could be mistaken for dilated cardiomyopathy. These are all different presentations that I have encountered. How do you deal with them? First diagnosis is usually by echo. In a few cases, we may need a CT angio or an MRI or cath. I'll illustrate some of the cases where that was required. And the treatment for the neonate in shock, we already said the importance of prostaglandins, supportive measures, including ventilation, fluid, inotropes, correction of acidosis. And surgery would be the procedure of choice in the first few months. And for the baby presenting with shock, you use the minimum period for stabilization. Try to take the baby in 12 to 24 hours. But if the baby is presenting beyond 3 to 6 months, that 3 to 6 month interval is because a unit's threshold will vary. Surgery versus transcatheter management will be based on anatomy and institutional practice. I'll show our own data with regard to this. Remember, coarctation may present with major associations like Turner syndrome. Bicuspid aortic valve is a common enough association and a reason for aortopathy. It may have Schwann's complex when there is LVOT obstruction, parachute mitral valve, and coarctation. Mitral regurgitation quite often, or extracardiac problems like Berry aneurysm and polycystic kidney. Here, we find that the arch is only the tip of the iceberg. Why do we say that? Because there can be far more sinister intracardiac anomalies that may occur in association with coarctation. For instance, large VSD is common enough. LVOT obstruction makes management more challenging, or complex anomalies like Taussig Bing anomaly, where coarctation may occur in as much as 30 to 50%. Transposition, single ventricle, hypoplastic left heart, all these where there is proximal arch hypoplasia and a smaller ascending aorta add to the complexity of coarctation management. So this was a baby, again, which I had seen in Muscat. Day 2 baby, 2.4 kg, with Taussig being anomaly and coarctation. We did a CT angio. You can see that the pulmonary artery is continuing as the ductus and the descending aorta. The aorta is small, and the distal arch and the isthmus is practically atreated. So this baby, we did undergo an arch repair by resection and extended end-to-end anastomosis initially, and did have a small arch gradient. Our idea was to ban the PA because this baby, we didn't want to combine a complex arterial switch with a arch repair. So we wanted to ban the PA, but the baby did not tolerate the PA ban. So the baby was kept on ventilator for 2 weeks and underwent an arterial switch. It had a prolonged ventilation, but eventually made it with a decent outcome. I started this talk by referring to coarctation in the fetus. In the fetus, the contradactyl shelf is, of course, difficult to visualize, and it may not be there because, after all, the coarctation is something that evolves significantly after delivery. And the ongoing process, we believe, is the constriction of the ductal tissue, which is there in the contradactyl wall of the aorta. So it's not your fault that you're not seeing a contradactyl shelf in the fetus. So the fetal diagnosis of coarctation would involve appreciating the smallness of the isthmus, the aorta, the left ventricle, and the other features. To explain that, normally the left ventricle is smaller than the RV in the mid-trimester fetus. But if it is abnormally small, we will define how abnormal is abnormal. If it is abnormally small, if the arch is small, then you suspect coarctation and very proactively look for it in the postnatal period. The things that you can look for are, say, if you relate the isthmus to the diameter of the ductus, as I'll show in the next image, they're more or less equal. But if the isthmus is less than 3/4 of the ductus, be suspicious. And the normal isthmus ductal angle, say the way the ductus joins the descending aorta, it's very obtuse. If it looks acute, that is a feature that the arch is small, and that is suspicious of coarctation. Isthmus C-scores are available today. And also, if you relate the pulmonary artery to the aorta, normally the PA is 1.6 times, up to 1.6 times larger than the aorta. If it's even more, suspect coarctation. And if you measure the mid-cavity diameter of the LV and the RV in mid-trimester, if the LV is less than 60% of RV, suspect coarctation. And using multiple parameters would enhance predictive accuracy of critical coarctation neonate. And longitudinal follow-up in pregnancy would enhance the accuracy of diagnosis. What we are trying to do is to predict which baby would crash due to coarctation in the newborn period. If they present more insidiously with coarctation, it is all right. We are not going to lose that baby. But the critical ones, if we can pick out, that will be great. Look at these two arches. This is the arch where you can see that there's a very wide isthmus. The ductus is not shown here, but it wouldn't be much larger than this. Whereas here, the entire arch is small and the aorta opens out only in the descending part. So this is suspicious of coarctation. And if you have antenatally suspected coarctation, if the fetal diagnosis was firm, you can assess the lower limb pulses and the forelimb BP, and it's unlikely to be abnormal until the ductus closes. You will decide on prostaglandin depending on how long you are going to wait and what the anatomy is in the beginning. And when there is no clinically evident coarctation, keep observing until an echo is done, and prostaglandin only after confirmation. Otherwise, it confounds the issue. Or if the arch is normal after a few days of observation, send the baby home. But remember, see the baby at 1 month or 6 weeks if you had suspected coarctation. Time and again, we have seen coarctation evolving later. And remember, coarctation is a progressive disease, and as I mentioned earlier, it's attributed to constriction of ectopic ductal tissue in the contraductal wall of the aorta. So this is a fetal coarctation that I had seen a couple of years ago, just at the middle of the COVID era. This was a 29-year-old paramedical graduate who was in Delhi, who came to her hometown, where my hospital is located. She was 34 weeks pregnant when I came. There was obvious LV-RV disproportion and a small arch. So she was observed for coarctation in the postnatal period, and it was confirmed at 2 hours of life. On day 4, we did surgery, a resection, and end-to-end anastomosis. Nearly 1 in 4 children who undergo that type of surgery could present with recoarctation after the first few months of life, and this baby surely did. So I did a balloon dilatation at 4 months, with which the gradient decreased from 35 to 4. And now the baby has been under follow-up for 2 years. It's doing quite well. This was the initial fetal echo. You can see that this is the mid-cavity diameter of the LV. Compare this with the mid-cavity diameter of the RV, and the arch is quite small. And this was the baby's postnatal echo. You can see that there is obvious coarctation. There's a little distal arch hypoplasia, and the blood squeezing past the tight coarctation. And this was the balloon dilatation at 4 months of age, serial dilatation with the Teschek 2, 5, and 6, with which the gradient had decreased. You can see the tight coarctation here, the balloon being inflated, and the coarctation opening up. The natural history of coarctation is available from the era prior to surgery, when the average survival was 35 years, and congestive heart failure, aortic rupture, endocarditis, intracranial bleed, all these could happen in a certain percentage. The surgical repair of coarctation in neonates and infants, we mentioned that this is the preferred strategy. Any neonate or infant with congestive heart failure or significant upper limb hypertension with a 20 millimeter gradient with the lower lip, this would be an indication for surgery. In older children and adults, usually it is upper limb hypertension. And surgery for coarctation, the different techniques illustrated with the images. See, the simple surgery that you could do is a resection. The surgeon removes the coarc segment and just anastomoses the descending aorta to the upper descending aorta. That's simple resection and end-to-end anastomosis. But if there is distal arch hypoplasia, the surgeon moves the descending aorta to the undersurface of the arch, to the concavity of the arch, so that there is a not a transverse but an oblique area of anastomosis to reduce the chance for anastomotic narrowing. And when proximal arch is also hypoplastic, that is when the surgeon likes to go on pump, go from the front, give antegrade cerebral perfusion, move the descending aorta to the proximal concavity of the arch, and actually do an end-to-side anastomosis of the descending aorta to the proximal arch. And sometimes the surgeon augments this with a flap of subclavian after sacrificing the left subclavian artery. And there is data to suggest that with these techniques, the arch does tend to grow after the surgery. The people have looked at what happens after surgery and balloon angioplasty. There's a study from India, from Bombay, where neonates with native aortic coarctation, the authors concluded surgery unequivocally yields better immediate and midterm results. There is no doubt about this. But there may be small number of patients who may be presenting critically ill, where there may be an interventional management for palliation until the baby will become fit for surgery. In older infants, balloon coarctoplasty has good early and midterm outcomes with acceptable re-intervention rates and could be considered a viable alternative to surgery, especially in critical patients with high surgical risk. And when you go for balloon dilatation, the indication is a pressure gradient of more than 20 millimeters of mercury between upper and lower lips. And the measurements that you take, you want to measure the proximal transverse arch, the distal transverse arch, the actual isthmus, and the aorta at the level of the diaphragm. The general principle will be you don't want to use a balloon size more than 1 millimeter more than the proximal segment, which is usually the isthmus just distal to the left subclavian artery. And we try not to exceed the diameter of the descending aorta at the diaphragm. And in a recoarctation also, there's both for native and recoarctation, we are following more or less the same. We try not to exceed 150% of the transverse arch, and we try not to dilate it for more than 3 times the actual coarctation segment size. So this was a 3-year-old child with a discrete coarctation, native coarctation with a cap gradient of 40 millimeter, which had good response to balloon dilatation, as you can see here. In an overview of coarctation in children, the Rosenthal noted that balloon dilatation would be the treatment of choice for recoarctation of aorta. There is no doubt that it is the first-line treatment. Whereas native coarctation is successfully treated with balloon dilatation if you're avoiding it in the first 6 to 12 months. The earlier you see coarctation, as I mentioned in the beginning of this talk, the more likely there is an arch hypoplasia, and therefore a simple balloon dilatation will not be enough. The 3 to 6 months onwards, you can consider primary balloon dilatation in discrete coarctation. In recoarctation, the saving grace for us is the scarring and adhesions from previous surgery. Even then, we must know that aortic rupture has been reported, so extra aggression while dilating a newborn should be avoided. And in the longer term, we do have concerns about aneurysm formation and recoarctation. These do occur after surgical repair also, but the incidence is more after balloon dilatation. This is a paper that my group from Muscat presented in the previous World Congress in Barcelona. Our data was on 35 infants with 45 procedures, 10 native and 25 recoarctation. The results were good, except that in 9 babies with native coarctation, we had good results, but 1 baby did not respond and underwent surgery. There was no major complication, even though some had access site occlusion responding to heparin. So when you compare surgery versus intervention, if you are dealing with children, success rate, resting BP, and whatever parameters you take are similar between intervention and surgery. Mind you, these are children, not neonates. And aneurysm is more for CAP, and freedom from reintervention is lower for intervention. So in the older child and adult, now we are dealing with a little more favorable anatomy for interventions. Therefore, transcatheter management is preferred. In smaller children, you go for balloon dilatation. And in older children, how old? More than 10 years, more than 25 kg, you would rather stent them. Because stenting will prevent elastic recoil, provides better and more predictable results, less vascular injury, and tacks the intimal flap to the wall of the aorta, reinforcing the weakened areas, thereby reducing the chance of aneurysm formation. It's possible to address arch narrowing by stenting the arch, and covered stents make even tortuous coarcs manageable. A covered CP stent could treat or potentially prevent aortic wall injury in 158 patients in the American COAST 2 trial. So the transcatheter management is balloon dilatation, primary stenting, and covered stent. I already showed this image, and we were discussing how to make the measurements and what yardsticks to go by. And this was the post-balloon result of that case. But in the older child and adult, the presentation can be a little more intriguing. At hypertension in the young, you need to be careful in looking for evidence of coarctation by looking at the lower limb pulses. An uncontrolled hypertension in the middle-aged, aortic stenosis with aortic regurgitation when you have an intracranial hemorrhage or a dissection of the aorta, in a patient with claudication, all these are circumstances where our alertness for looking for a coarctation must be good. Quite often we discuss it, we discover it incidentally. Some of the clinical signs are worth recapitulating at this point. Mind you, in the general examination, the adult look for Turner syndrome, look for upper limb muscles which are better developed than the lower limb muscles, a left thoracotomy or sternotomy scar, which suggests that the present problem would be a recoarctation. In the cardiovascular system, upper limb hypertension, especially hypertension difficult to control on multiple drugs, radiofemoral or brachiofemoral delay, diminished or absent pulses, along with diminished or absent left or right radial pulse. See, left if it's a pre-subclavian coarctation, and right if there is a post-coarct aberrant right subclavian. Suprasternal pulsations, visible or palpable collaterals, all these are manifestations of coarctation in the older child and adult. This is how some of the typical collaterals show up in a CT angio. Mind you, the purpose of the collaterals is to connect a pre-coarct artery to post-coarct aorta. So one of the common things is internal mammary, which is subclavian, pre-coarct. Internal mammary divides into superior epigastric. It connects up with inferior epigastric. So this is internal mammary. It's dividing into superior epigastric and musculophrenic. The superior epigastric is coming down and meeting inferior epigastric, which is a branch of the external iliac. Or anastomosis around the scapula, which is between subclavian branches and the posterior intercostal. Remember the old teaching about the Sussman sign, where you ask the kid to touch his toes, kneeling forward, looking downward, and you palpate the inferior angle of the scapula. In the X-ray, you look for rib notching. Remember, the rib notching is from the 3rd to 7th space. In the first 2 intercostal spaces, the posterior intercostals are pre-coarct, and that's why you don't find it. Find any rib notching. Then you find a left ventricular apex, an aortic ejection click, evidence of aortic stenosis and aortic regurgitation, a bruit over the left interscapular area, and continuous murmur over the collaterals. This is the rib notching, which is highlighted here. This is downloaded from the net. The prominent aortic knuckle and the aortic, the rib notching of the 3, 4, 5 ribs. ECG showing LVH with strain. Echo showing in this case, the typical ischial narrowing with the Doppler showing the diastolic tail. In the adult, quite often coarctation versus pseudocoarctation is a question that comes. And some of the differentiating features are this. Hypertension is sort of inevitable in coarctation while variable in pseudocoarctation. There is no ischial narrowing in pseudocoarctation, nor any radiofemoral delay. And the arch is elongated and kinked in pseudocoarctation. And pseudocoarctation has no rib notching or collaterals. When you are managing the older child and the adult, the AHA recommendations would apply. It's nice to look at the AHA recommendation for stent placement. The class 1 recommendation is a recurrent coarctation with a gradient more than 20. And class 2A is a native or recurrent coarctation with a similar gradient or less gradient with systemic hypertension, or a long segment coarctation with more than 20 millimeter, or native or recurrent coarctation with failed balloon angioplasty. And class 2B, when a complex aortic arch obstruction persists after surgical or catheter-based intervention. And in this review of stent repair of complex coarctation, there was a technical success rate of 100%. There was one death in a 52-year-old man with a bare metal stent and 1 stroke. In 80%, the need for blood pressure medications could be avoided. And the actuarial survival at 15 years was 92%. Now, when you use stents for coarctation. At the beginning of this, I was having a chat with Dr. Rohit Manoj about the currently available stents. Cook formula stents are very useful for the younger child because it's a hybrid open cell design. It is a lower profile, but right now it is not there in the market. The CP stents have always been there in the market. They have a bigger profile, and so in that they need a bigger sheath to go through, and they're more expensive. The Andra stent is a little better in terms of cost and profile. The Sapphire has is a balloon expandable, non-foreshortening Indian stent. Both covered and uncovered are available. Covered CP stent is the common covered CP stent that we get. Covered Andra stent, B graft, Sapphire, all these are stents which are in the market, but which go off time to time. This is a case that had come to me several years ago. 43-year-old lady with coarctation, severe aortic regurgitation, systemic hypertension. Amazingly, she had undergone an aortic valve replacement with a Carpentier-Edwards valve in the past when coarctation had not been looked for. She came to me with worsening aortic regurgitation for evaluation when coarctation was evident, and she was on at least 5 drugs for the control of hypertension. And this was her CT angio. You can see the tight coarctation. This was in the time of the atrium advanta stent, which is now withdrawn from the market because of its recoil. But this patient had good result with atrium and did not recoil for several years on follow-up. A covered stent 12 millimeter into 30 millimeter got treated. There's an unusual arch. You know what is the circumflex arch? Is if you have a right arch with a left descending aorta, or the other way around, a left descending aorta and a right arch. These are the circumflex arches. So this is a 14-year-old boy who had neonatal coarctation repair, presented with recoarctation, and he was stented with the Genesis PG 3910, which is no longer available, on a 14 mm Optapro balloon. The little funny look of that arch is because of the circumflex nature of the arch. This is a very tough instance that I had in Muscat. This was a 3.6-year-old child which had been referred to the surgeon from elsewhere for coarctation surgery, and the surgeon had asked me to see, saying that the child had cyanosis in the feet, which he indeed had. This was his anatomy when I catheterized the baby. You can see that the ascending aorta is quite small. So this is as if it's a hypoplast variant. This child was living on a duct with a ductal aneurysm, which was supplying the lower limb. And that is why the child had differential cyanosis. And the child had severe distal arch hypoplasia. And the child had bilateral PA stenosis. So it was as if the child had a physiology similar to hybrid Norwood. He had failure to thrive and lower limb cyanosis. We were wondering what to do for this child. It was my idea that we could buy time by stenting the arch. So we stented the arch with a Cook formula 8 mm stent. This relieved coarctation substantially and preserved the ductal flow. We didn't want to interfere with the ductal flow. The child lived for 3 years, and later a surgeon attempted surgery which the child didn't tolerate and succumbed. We also get some weird cases. There was a CSI in Dubai where I was one of the people involved, presenting from Muscat. I had this 57-year-old Arab lady who was mother of 8 children, and the youngest child was 25 years. She was hypertensive for 20 years, diabetic for 10 years on anti-diabetic and anti-hypertensive medication. She had a class 2 effort dyspnea. She didn't seem to bother much with it. She had an upper limb BP of 180 by 84 and a lower limb BP of 94 by 60. And this was her arch. Why I have called it the case that wasn't, our plan was to do this case live with a covered stent. But on the day of the procedure, the family refused consent, so we couldn't do it. But to the best of my knowledge, for the next 3 years, she lived without any problem. It's not that something happened to her after 3 years. I have no follow-up after 3 years. Many of our youngsters push the boundaries of managing coarctation. Once in a while, we get cases like this where there is an ischial atresia. This case has been shared with me by Dr. Pushin Chavan from Navi Mumbai. I had a similar case, in fact, maybe 20 years ago. In this, you can see the obvious problem. There is no continuity. So what Pushin did, he could not cross from below. The pigtail outlines the seemingly blind part of the aorta. So he went from the subclavian, crossed with a CTO wire. He is trying to cross with a CTO wire, and followed it up with a prograde catheter. Then got a thermo wire, exteriorized the wire from below, and then got a guiding catheter across the coarctation from below. You'll see it in this image. The guiding catheter is coming up from below. And now with a guiding catheter across, the rest of the procedure is fairly straightforward. And this was a case where he used the sapphire stent. You can see the sapphire stent being deployed. You can see that the stent is coming up. And this was the final outcome. So from an atretic isthmus to a wide open with the stent treatment, this is an excellent result from Dr. Bhushan. But let's remember that at all age, surgeons also have their role in managing coarctation. This particular child had been under my follow-up in Chennai, the only child of Tamilian parents, had a neonatal balloon aortic valvotomy for severe aortic stenosis and surgical repair of coarctation 2 months later in the early 2000s. The child came to me for balloon dilatation of recoarctation. I did it at 6 months and 2 years. At 4 years, she seemed to have a viral myocarditis, a poor LV function, and a stroke. At 15 years, she presented with upper limb hypertension and LV dysfunction. And she had transverse arch hypoplasia and long segment ischial hypoplasia. So my surgeon in Tiruvalla treated it with a ascending, a proximal transverse arch to descending aorta graft through a left thoracotomy. These people could not afford any expensive intervention-based treatment. So you can find that you have a small arch and you have a very small, long hypoplastic isthmus. So a graft from here to here treated that. Let's also remember that coarctation requires long-term follow-up. You have all sorts of problems like local vascular problems, ascending aortic dilatation, essential hypertension, aortic dissection. Be on the lookout for premature coronary artery disease. Remember, 50% of coarctation in children have hypertension at the age of 40 years, be it due to imperfect repair or due to inherent part of the disease. And all these are potential problems in adulthood. And some of them are women, and women may present to you in pregnancy. Remember, they require both a preconception evaluation and counseling. There's a 5 to 7% risk of congenital heart disease in the fetus. And you need to look for hypertension, aneurysm, and residual coarctation. And risks in pregnancy would include hypertension, dissection, preeclampsia, aortic rupture. And pregnancy needs to be managed with a multidisciplinary team with meticulous BP control and beta blockers. You need to monitor ascending aortic size and aneurysm size if present. You may need serial MRI. Remember, contrast is contraindicated. And the delivery is assisted second stage. Endocarditis prophylaxis needed. So coarctation, as we mentioned in the beginning, is a disease that challenges care providers all through life, from fetus to adulthood. And interventional cardiology has made rapid strides in the last 25 years, treating the most complex of coarctation in older children and adults. As we understand the anatomic consequences and the physiologic effects of rigid stents, the ultimate challenge is to evolve a management strategy that normalizes vascular function in the affected aorta. Maybe bioreabsorbable scaffolds may be a step in this direction. Thank you.
Okay, thank you, sir, for that wonderful deliberation. So, I think it's now open for discussion. Maybe our esteemed panelists could make some comments or questions, and then we can have questions from the participants as well.
I have some comments. It was
Yes,
a very
yes,
nice
sure.
presentation, very comprehensive presentation. Reflects his long experience of dealing coarctation. So, I mean, the whole gamut of coarctation from intrauterine life till adulthood is very well dealt with, I think. See, regarding the intrauterine period, one clue which he has already told is that the right side dilatation. It's not easy to image the arch. It was a difficult one, especially in the older machines. But last few years, the image quality has improved so much that I think it is possible now to recognize the arch and the distal part of the arch. One easy clue is significant right heart dilatation. Other thing is the closure line of the aortic valve. If it's an eccentric closure line, it could be a bicuspid aortic valve because it's not easy to easily identify a bicuspid aortic valve in the fetus. So this could be a clue, and these babies could be observed for subsequent development of coarctation. And in the newborn period, this comment is basically for cardiologists who are predominantly on the adult side and are not involved in pediatric practice. It's not easy to diagnose coarctation for people who are not used to seeing coarctations in the newborn, because many times in the peripheries, neonatology units, they call whosoever cardiologist is available to get to know what is happening. The important clue again here is baby is in heart failure, but right heart is dilated. So if there is a VSD or a bicuspid aortic valve, look for coarctation. And the other thing that we have observed is in many of these babies, the coarct will manifest after a few days of observation, because the duct is open and baby is doing well. The clue here again is bicuspid aortic valve or presence of a VSD. If these two are there, then if there is a doubt about the isthmus, keep the baby for a longer period of time, as sir said, and wait until the duct closes. If after duct closes, if the isthmus is measuring about 3 millimeters or so, or more, then it is safe to send them home. If it is less than 3 millimeters in a, say, 2.5 or 3 kg baby, then you should keep your red flag up and watch the baby again, might need early intervention. Regarding comments regarding the stent, sir, the new stent called B stent is available. We have been using the stent. It has got, it can go through 11 French or a 12 French size sheath, and it can be expanded up to 22 millimeter. So we used to use a lot of these atrium stents earlier, but they are not available now. And our experience with CP stents has not been so good. The older CP stents which we implanted, many of them have developed fractures. We do lost today, but lumen is not lost. And the present Zephyr stent we have used in significant numbers, it lacks the radial strength. We will have to dilate it again. And when we are dilating in younger individuals, we don't dilate to the fullest extent. We leave a constriction because many of these the stents, they tend to slip off because the lower part, the post-stenotic part is huge, and the stent is hanging free without getting attached to the dilated aorta. So we bring these patients back about a year or two later if there is a residual stenosis, and then redilate that. Another point about recoarctation and stenting, we have had adults where they had undergone surgery and we subjected them for balloon dilatation. And we noticed that complications of balloon dilatation are high. We should be prepared with a covered stent in most of these cases. And 2 or 3 group of patients who are very prone for rupture and dissection. One is Turner's, other one is long segment coarctation. Third one is recoarctation in adult, which usually does not give up easily, so we end up doing high pressure dilatations. And fourth one is aorta arteritis, which also causes coarctation, though it is an acquired disease. And in adults, especially borderline adults, I would say 40 kg, 35 kg, or even 50 kg adults, where the femoral arteries are slightly smaller, access site complications have been a problem. So some of them needed covered stents because of the access site complications of femoral arteries. Thank you.
Great. Sir, Dr. PV Suresh, sir, what you were mentioning, I think that's a problem many of us face. Like, we are adult cardiologists or predominantly adult cardiologists, but sometimes or quite a few times we are asked to do echos on young children in neonates and infants. So,
Yes.
like you were mentioning, so is there any role of just like all the diameters, measuring the diameters and all of them? I think it needs a bit of practice for young people or maybe people who are not so used to it. What are the fallacies or how accurate is just measuring the gradient from the suprasternal view? So if we just
I
take
think
the 20 millimeter cutoff, how specific or how accurate is that? So,
it is quite accurate. I think first thing I would suggest is the adult cardiologist. Since I practice both, the major I would not say fallacy. I would say the major limitation is the probe that you use. If you use a pediatric probe, you will not miss it. When we are using a lower frequency probe, the tendency to miss diagnosis is higher. So if you are routinely being called for a pediatric or a neonatal echo, I think you should insist on that hospital to buy a pediatric or a small footprint probe with a higher frequency. That itself will make diagnosis pop out in front of your eyes. There is no big deal at all. I think diameters, sir, already mentioned.
yes.
Yeah, I think measuring diameters and looking for other surrounding things like bicuspid aortic wall is a is immediate giveaway. I mean, if there is a bicuspid aortic wall, then I think you are dealing with a coarctation if there is a narrowing in the distal part of the arch. And most of these neonatals coarcs which present, they also already have transverse arch hypoplasia, which sir said. Only those which have transverse arch hypoplasia will present in the neonatal period or early infancy. Rest all will present at a later date. So I think you should insist on having a good probe. I think that is easy.
I'll just amplify the point that Dr. Suresh made. When you are in doubt, 2 things I would suggest. One, feel the pulse.
Yes.
If you feel the lower limb pulse, or rather, if you feel that you cannot get the lower limb pulse as well, think that there is coarctation. One. Second, when you are in doubt about the gradient and the isthmus and all, if the transverse arch looks small to you, there is very likely there is coarctation in the ongoing segment. These are 2 simple things that you can think about. Absolute measurements are different. It's nice if you do that, but even without that, one, failing to get the low, I don't even ask you to feel the femoral pulse. The baby may not allow you. Pedal pulse. If you can't get the pedal pulse, if you find that the arch is small, then very likely there is coarctation in that setting.
Yeah, I would just like to add a point here. when I joined PGI, Dr. P.S. Bidwai had already left. He was a great teacher and I missed him. I joined PGI in 91 for MD medicine. He had already left and I think he had gone to SGPGI. But in between, he used to come to PGI to visit his friends. So he used to take classes for the DM cardiology fellows that time. So I attended one of his class and he told, सभी बच्चों लोगों का पैर छूना है, बच्चों में भगवान रहता है. This was in reference to the coarctation. He said, never ever leave a child without touching their feet. That I think has stuck to me in my mind all the time. And whenever I'm talking about coact, wherever I go, I always mention Dr. P.S. Bidwai. It's a very nice way to remember things. Never ever forget touching the feet.
Yeah, actually, much of the pediatric cardiology that I think, teach, read, I attribute it to Professor Bidwai, because my generation, I found Dr. Jagan Mohan Taragan also in the panel. I think among this, only Dr. Taragan and me, if I had the good fortune to be Professor Bidwai's students, it was great.
Yes.
Okay, so any questions from anybody?
Saujatya, can I say?
Yes, sir. Yes, sir.
So I think wonderful lecture, sir, and PV Suresh sir has emphasized the issue. I often find that if you find a VSC child who has an unexplained pH, we expect large VSC to have pH, but suppose you have not so large VSC and you have an unexplained pH, I have often found that coarctation is often missed or R supply is often missed. That probably was one clue. Add to the what they have already said. Dr. Suresh has emphasized that more and more adult cardiologists are using covered graft stent for his sir said that about the aneurysm, additional PDA is there, or if you have a long arch is there, or a recocked adult. There's another and besides Turner syndrome, whenever you are using CTO on what we have done few cases of chronic total occlusion coarctation. And if you employ only bare metal stent, it is simply difficult to dilate completely. So in such a situation, you need to employ a higher pressure balloon. You have to use covered graft stent. So if you open completely occluded coarctation from the radial approach with CTO wire and all this thing, you have to have a covered graft stent. A lot of center, of course, advocate covered graft stent routinely in adult, not a correct practice for looking at finances, and I think finances is the main issue. The second thing is that balloon mounted stent, a bib, is often a good idea to use in tortuous or difficult anatomy where a stent position might be very easy or reposition might be easy in difficult tortuous anatomy. I probably would tend to use bib stent in a tortuous anatomy, not a simple say Zephyr or simple balloon hand mounted CP stent. A lot of adult cardiologists I have seen in North India using self-expanding stent. And if you happen to, not a good idea, I think if you happen to do that, and if you have to dilate them, you simply will end up in fracturing the stents. So you have to use a good radial stent. We used to have Cordis stent, now it's no longer available. That also used to fracture. Even Dr. Suresh has said CP stent also gets fractured. So you simply should not think of using a self-expanding stent. Thank you.
So what happens if the stent gets fractured on table? What do we do then?
I mean, my experience is not good. I have sent for surgery because one of the patient had ruptured aorta. So we had to give immediately put the child on bypass. Not a good idea, because the even though we think that there are spikes getting, my patient got ruptured aorta, so I had to send him for bypass surgery. I probably would try. I'm not sure covered graft, but I have no experience with that.
Okay. And
Durga has to say something. Durga, how are you? Durga,
Sir, I'm fine, thank you.
Durga is meeting up, seeing you after a long time. Say something.
Nothing, sir. Sir, I'm not practicing pediatrics much. I'm happy to listen. to you.
He does a lot of coax surgeries, so say something.
All that we know of congenital or pediatric cases are because of Manoj sir only, I think. Our
No,
Yes,
generation,
yes.
all of us. So he is the Professor Bidwai of our generation, I think. Whatever
no,
we know is because of him.
don't compare me. Don't put me into that category. I'm not that category. Don't put.
Sir, just one more question, if I may ask, sir, about this CMR. So when do we do CMR? When we are planning an intervention or just for diagnosis, or when do we do this CMR? Because
I think it depends on center to center variation. X-ray, CT involves a lot of radiation, right? It gives a beautiful picture, 3D picture, and all this thing. But if you have to do repeated, I think Suresh sir has said, coarctation is a lifelong disease. It is not that you have treated or you have stented and you have got a. If the patient has hypertension, is adult coarctation hypertension, likely that very fairly good chance that he remain hypertensive, and the long-term follow-up is required. In such a situation, you want to avoid radiation. A lot of centers do MRI as a method of choice.
so I guess in younger children they might move about, and you'll have to, I guess, sedate them before.
Anesthetize. Yes, anesthetize. Younger children, first surgery and all, we routinely do a CT.
CT.
And all CT. And if it is balloon dilatation only, CT, I mean, MRI is good enough because it will save radiation. But if you have stented, because of the stent artifacts, you can't get a good image of the coax segment. So you will have to do with CT scan. There is no alternative.
Right.
So may I ask Dr. Suresh sir? Last PCC I attended one of the RR hospitals, pediatric cardiologist. He's young, and I'm sure they have a lot of free hardware available. He so presented data on a neonate with NC balloon as a routine practice instead of surgery. Not a good idea. It's not our. I don't think he has published the data, but he was very categorical that NC balloon is the way answer of surgery. There's a lot of people are questioning. Have you published? He's not published. What is your take on that, Dr. Suresh sir?
I completely agree with you. In that, I disagree with the practice. But having said that, there are a few instances where, you have a baby presenting in extremis. You are in a center where there is no surgical support available. Baby is in renal failure. So if you are doing a balloon dilatation in such a baby, or even a stenting, especially with one of these newer coronary stents, which is a reabsorbable stent, there are isolated instances of such reports, which in a given setting is justified, but not as a general practice. As a general practice, as a general instruction, I would say neonatal coarctation is best treated by surgery. And
Yes,
the
I
younger
agree.
the infant, the best treated by surgery. The moment you have reached 3 to 6 months, then you enter a comfort zone to look at the anatomy. And if the coarctation is reasonably discrete, we can have balloon dilatation. But if there is a significant arch involvement, it is wrong to do pure balloon dilatation. So that baby will have a residual coarctation.
I fully agree.
I'm not sure how he's so confident and on that this is my data and all. I simply couldn't digest it. That's why I asked the question. Of course, it's sick, very sick, CCF and sepsis. Would prefer balloon dilatation. We also do the same. We do balloon dilatation. Stabilize it, and then later on, if required, recoarctation happens, we send for surgery. Right.
Yeah.
Thank you.
One of the problems in babies coming in extremes, the one in cardiogenic shock and renal failure, low output state is getting the access. So what we have done in some of these cases is gone through the venous side, crossed the PFO, gone across the aortic valve, floated this thing, PTCA wire and whisper wire, and then balloon dilated. We haven't stented any, but these are very few in numbers. Nowadays, they come early, and there is a big, very good pediatric neonatology facilities all over the district places, all over in our surrounding areas in South India. So those days when we started long ago, 22 years back, when we used to see at least few cases a year where they needed neonatal dilatation just to make them, keep them alive for the surgeons, those we haven't done for a long time.
Yeah.
And children where we have had multiple recoarctations, especially in children who are below 20 kg, where stent was the only option. We have done carotid cut downs with the help of surgeons and put stents. It has worked out very well.
But like you said, mercifully, these things are becoming uncommon with increasing early diagnosis of coarctation and even fetal diagnosis of coarctation.
Yes. But I'll tell you the downsides. All these are getting terminated because the equipment has become so powerful, and the radiologists are so experienced now. They are making diagnosis of not just coarctation, corrected transposition, small VSDs, everything that is there in pediatric cardiology, they are able to diagnose.
And counseling.
And counseling. And what is happening is, I used to see, since ours is a big center, I used to see a lot of complex congenitals. I go to the periphery also. Every month I used to see virgin cases of heterotaxy, AVCD, transpositions. They have all disappeared. In fact, there was a time about 10, 12 years back, in a year we operated 120 transpositions. Unbelievable.
Yeah.
Surgeons themselves could not believe that they had operated 120 that year. From that situation, we are now operating hardly 2 per month, that too with difficulty.
Yeah.
And all getting terminated. So these coax, if the radiologist and they have got a second opinion from another radiologist, you can come to the pediatric. They just get terminated at the obstetrician's level. That's unfortunate, but that is true, I think.
Is it medically correct to advise termination for coarctation?
See,
that's a different topic, but I think the pregnant lady and their family have an absolute right until it is 20 weeks.
See, if you are able to convince the mother or even to plant a doubt in the mother's mind that this is going to be trouble postnatally, the mother might want a termination and there is nothing preventing it.
They are very clear. I'll just share one small instance. There was a VSD which was clear cut. Isolated VSD, rest all was looking normal. 18 weeks. 3 different people diagnosed in the city, including the top fetal cardiologist, fetal echocardiographer, very senior radiologist. His reports are invariably right. And they came for counseling. I said, we'll operate after baby is born when it is needed in follow-up. Excellent outcomes. She had a question to ask. You said excellent outcomes. What does it mean? I said surgical outcomes, if it is done in the first 6 months, are close to 98% survival. She said, what about pacemaker? And she had prepared everything. What about pacemaker and pacemaker and resurgeries? I said they are very low. Then she said, what happens to those 2%? Then I said, it is unfortunate. She said, I don't want to be in those 2% or in that pacemaker where I have to take it through lifelong because I want to live my life. I don't want my baby to go through the surgery. I already know it. I'll go for another baby. She is upfront and I was taken aback. The younger population is completely different.
Yes.
Yeah. She said, both myself and my wife, my husband are working. We are living alone here. My parents live elsewhere. His parents live elsewhere. I don't think they can support us to a large extent. You don't expect me to bring the baby every 3 months in the first year and thereafter, God knows how long, when will you operate. I don't want to go through that trauma. I guess she had a point, but I was a little taken aback. That was my first experience.
It's very unfortunate that VSD, coag, and TG is getting terminated. That's probably that's a different topic to discuss, right?
Yes.
But the generation is changing, right? So, Dr. Suresh and Saujatya, thank you so much. Unfortunately, I am not in Chandigarh. I am in different meeting. I will take.
Okay, sir.
Thank you. Thank you, Manoj. And Saujatya, I must also
say, I think it was a very wonderful. I'll conclude this meeting. So thank you so much, everybody, for joining in. I think it was educational. We'll put this up on YouTube also, and more people will definitely get benefited. Thank you so all for everyone for joining.
Nice meeting all of you, particularly PV Suresh.
Yes. Thank you. Thank you.
Thank you.
Bye.
That's how I'll close this meeting. Yes.
Yeah.
Goodbye.
Bye.
Thank you.